We do not all age in the same way, and therefore, and a young person could have the same complaint that the old person had also.
It's not like it used to be, and I do know their time is taken up with a lot more patients.
I think they should share the information, and then it will keep you repeating it, because you might not remember what you said before. Because it might be a couple of months and you've forgotten.
You don't want to go to a doctor to see a grumpy face.
I don't speak proper English. You know, have all the records to the hospital. And the doctor check up to you. No want to speak to you.
More understanding so that the patient will feel happy when he leaves the surgery.
Each time I've had to go and I've seen a consultant, the consultant has taken a great deal of trouble to listen, to answer you and to talk to you.
I think the idea of patients as teachers is a really important one. It's a very simple tool, a very simple technique that allows the voices of people who've been dealt with by professionals, whether it's social workers or nurses or doctors, to be heard, and they can then teach professionals good practice from the user's point of view.
We've been involved in patients as teachers through Direct Routes Consultancy. We specialise in talking to service users about their views on services and how they'd like to improve them. We've had a team of people carrying out interviews in people's homes, and we'll be pooling together all the information that we've got to produce partly this video and also good practice guidance so that we can actually learn from older people's experiences of assessment and improve on the services that they will receive. It's much more powerful when older people say the things than when practitioners say the things on their behalf.
Part of the issue is just the time that we have, but part of it is encouraging us to see patient views as important and making them relevant to our day-to-day practice.
It is important that they share the information about you because this thing is happening to you.
For practices in particular, it's very difficult. We don't have a tradition of listening to what users say, and we are incredibly busy, and it's very difficult to change our practice.
When we ask a question, answer it.
Answer it, don't go around the houses. All you want is a straight answer, and you don't often get that.
If it's anything, you have to put it to them. Say, well, doctor, send me for an X-ray. I want you to sound me, and I think that is not right. It could be dealt through an interpreter. It will be easier for the patient and for the doctor as well, because the doctor will understand her language.
When you assess a client, you actually always check in whether this is suitable and whether this service is suitable or not. And if they say not, then you try and find an alternative. And it's about listening, but it's also about knowing that they're the experts. Potentially, because we're busy as social workers and our jobs are very demanding, but you've got to make time to listen and to respond to the ideas that clients offer, because they're the experts on their own needs.
I think if they studied the notes and found out, what had gone on before, because everybody writes notes, they would have a bit more idea of, what was going on, rather than keep asking you the same questions that you've just answered.
If there are notes that are made about an assessment visit, then the individual would like to see those notes.
When you ask a question, 9 times out of 10 you're told, don't worry dear. We know what we're doing. Some of them now in the hospital know me, and they say, you tell her step by step, otherwise she'll walk out on you. I want to know what's going to happen to me. I have a right to know that. And therefore I should know, then I can make a decision. And it's those sort of things where you're asked, as you say, the same question over and over again. It may be necessary, but we want to know why.
It would be nice if a patient had a copy of that information, and when they saw a different person, they could show that.
When my GP and I have a good chat, and you send me to a hospital or any place to appointment. I say to her, write it down and give it to me, what I got to ask the other department about. And then I take it with me.
Well, I think you have to try and say it in words that they will understand. I mean, if you're a therapist, you know all this language, but the people you're treating don't know it all. You've got to explain what you mean.
It doesn't matter some people's age, people do forget things. And it would be more informative for the doctor or the nurse, health visitor, to write it down in plain English that we, the patient, can see and can read.
A lady I knew, she had a stroke, was in the hospital for some time, but she's disabled, terribly disabled. I asked her if, about attendance allowance, and she said she never heard of it. She didn't have a rail for the toilet seat. The moment she came from hospital, shouldn't she know about those things? And she didn't know nothing at all about that. She didn't even have a social worker.
So she'd really slipped through the net when she'd been discharged.
The key worker could actually liaise with the carer, also with the client, and maybe the professional coming in, so that if there is information to be passed on, there is a key worker, whether she's there or not. It would help if, for instance, the message could be left in the communication book so that someone could refer to it.
Some people talked about their blue folders that were kept at home, district nurses and other professionals putting information in there. And a number of older people were able to bring their blue folders out and talk about who to contact. They knew who to reach, they knew who to ring to get further support and services. More of that type of practice would be a good thing. Actually enabling people to hold on to their own records and take responsibility for that, and to share that information with relatives, carers and other key people in their lives.
For instance, if they're talking about the way we deal with people, if they talk about being nice to people, being respectful, listening to what they say, well, that really is obviously good practice, and we should be doing that, and we should be organising our time to ensure that that's possible.
Some are extremely nice, because some will shake your hand and put their arm around you and say, good morning, Olive, and it's really one-to-one with you, and you feel good. Be friendly. Call it by your name and shake your hand and put your arms around you if it's possible, and be more friendly towards you. It eases the pain tremendously.
Listening perfectly and ask them many questions to learn what problems we got, and what I say, and smiling every time, not nervous, not upset, not tired for the people. Make them happy for us. And
you're going into their home, it's their privacy that you're infringing, so you have to go and let them have dignity and respect for where you're going and who you're going to see. They're much older and much wiser than us in years, and therefore we have to respect them at all times.
Find out exactly what is wrong with me before saying, oh, it is your age, it's because you've gotten old why these things are happening to you.
I notice as you get on in years, hospital doctors don't seem to want to know. No. When you get on in years.
Well, you're living too long.
They don't spend too much time with the hospital doctors, and I've been there enough times.
They get a bit impatient and talk to you roughly. They don't mean it, but I can understand that they haven't got the time. They're probably rushing around to go to somebody else after me.
And I said to the people making the appointments, could I see a female doctor? There were all these men standing behind me, and she said, why?
Age Concern are doing a big study at the moment about gay couples and how, when they're older, how they can't, like heterosexual couples, will automatically be in sheltered housing together, but for gay couples, they're often split up because it's not. The assumption is that they're not a couple.
And trust is important, and this goes back to saying that sometimes you need to get to know people over a period of time. You can't go in and rush into things really, and not being judgmental as well. Like Jeanette said about sometimes when you go into houses and you think, well, they shouldn't really be living like this, but that may be their choice, and you've got to respect that sometimes.
People should be made aware of their rights and entitlements under complaints procedures. Be given information in writing. Actually make sure that they're listened to effectively.
That if they complain, that it will be taken out on their relatives.
Oh yes, that's often happens, and we have instances of it happening. There again, that makes you more reluctant as well to complain about that, because it will be taken out on the patient.
But I've got a doctor, and she's very, very good.
And what's good about it? What makes for a good doctor? That's partly what we're here to find out.
She listens to you, she talks with you, she asks you how you're feeling, where you have the pain, and she examines you, and she tries her best to give you something to help her to ease the pain. See, and I can't complain about her really.
Doctor writes what I problem, why I am stuck, and I write when I'm learning. It's good.
Someone to sit there and explain what they're doing or giving you. And what it's supposed to do. Because not every tablet agrees with you.
That's right.
So I must know what I have, what I need for my healthy lifestyle.
Again, doctors don't have time to do this sort of thing. So perhaps, they should go into a nurse and a nurse could chat to them and say, what do you want? Or, somebody who's got a bit more time.
Because they need to know you're reliable and that you are constant and consistent and you will do what you agree to do.
It's making sure that doesn't just stop at the assessment, that you actually go through with it and that you make the appropriate referrals and that the person sees the changes are actually made at the end of the day. That it does.
When the doctor came on the ward to speak to me about the operation, and I really did not understand some of the medical terms, and I asked, please, could you write it down for me? And he obliged and he wrote it down, and I really, really felt very thankful to him. I was grateful, because when I leave after the operation and somebody asks me, what did you have done? I was able to look at the paper and say exactly the kind of operation I had and what it was for.
So they wanted information in writing, things put in writings for when they maybe spoke to their carer, relatives or support. People were very unhappy with telephone assessments. That they'd rather have seen somebody face to face. What we've found is that people are very grateful for any service they receive, really, and are also reluctant to complain about any poor level of service.
Patients produce a lot of ideas through the patients as teachers process, and most of them are really simple. They're not expensive, they're very straightforward, and they're usually about attitudes and simple organisational ideas which would help us to do our job better.
The good practice guidance become a real living document that all practitioners use, refer to, change their practice, and really look at improving the service delivery. We also would like it to be reviewed and changed, and for it to be a living document. And because it's been brought together by older people and practitioners, hopefully it will be something that's very real for people and can make real changes in practice.